Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. In this episode, we focus on a discussion between expert faculty and people living with HIV regarding health-related quality of life. Joining me today are Dr. Iskandar Azwa, Dr. Beng Eu, Mr. Nikos Dedes, Mr. Jeff Taylor, and Ms. Bernadette Sharp. To follow along with the accompanying slide set, please visit the link in the show notes for this episode. Now, let's get started and hear first from Mr. Dedes, who is going to share a personal experience with improving his own health-related quality of life.
Allow me to give a personal example of what pursuing a better health-related quality of life meant for me personally, sticking just to antiretrovirals. I started therapy in 1997 with 2 out of the 3 drugs which were included in my regimen that have been taken out of circulation because of toxicity. One of my drugs consisted of a chewable tablet with a horrible, for most people, taste. People likened it to chewing chalk. I was actually an exception and did not mind the taste of it, even perversely liked it. And it was the first thing I had to do when I woke up in the morning, because you had to take it far from other medicines. So one day, after 2 years of taking it, I wake up, I look at my pills, and I could not bring myself to put them in my mouth. I simply refused to do so, and I had to switch. It was impossible for me to repeat the same thing of chewing the chalk. So in these 26 years, I have used 12 different drugs, 5 fixed dose combinations, and changed 17 times, always retaining viral suppression, but wanting to avoid long-term toxicity, as well as for convenience, considering number of pills, daily doses, food restrictions, interaction with other drugs. Jeff, may I ask you, in the healthcare setting, how does your healthcare professional assess quality of life? What type of things do they ask you?
So as someone, over 50, I'm actually 61 now. My HIV is the least of my concerns. My viral load is stably suppressed. I tolerate medications well. So it's everything else that I have to deal with, all the comorbidities that come with aging. I have inherited hypertension and gastroesophageal reflux disease. So to manage those. So that's kind of the challenges that I have to deal with. And then, as a sexually active gay man, they ask about my sexual health, and not just prevention, the latest things like doxy, PrEP, and PEP, but also addressing things like erectile dysfunction, hormone replacement therapy, managing that effectively. So those are the things that I wish more providers would do, because many haven't over the years. And I think everybody deserves that, because quality of life is a big part of that is quality sex and enjoyment. It's something everybody deserves.
No, thank you. If I can ask, Beng, how do you in your practice assess and document health-related quality of life?
There's sort of 2 ways I would normally do it. Quite often we just have open conversation with our patients about sexual health, mental health, what's on their mind, and we're aware of the barriers people are having to quality of life, so we ask specific questions. But the other way is, of course, there are now lots of quality of life questionnaires available, and maybe we're using that a bit more, and that can trigger more questions as well. There are probably 2 ways we can do it. We haven't been using the questionnaires much, but I think we should be increasing that now.
And Iskandar, can I ask you the same question? And also, is this then reviewed? And is there some things acted upon?
Yeah, I think over the years, we've become better at looking after patients and really paying attention to comorbidities. Aspects of aging, as clearly Jeff had mentioned, sexual health. I mean, certainly where I practice, sexual health is still very much a taboo amongst the ID physicians, but very much adds to the quality of life issues. I prefer very much, and I think my team at prefer a very informalized approach. I think there's a call towards moving towards questionnaires and formalizing everything, but basically paying attention to comorbidities, and that includes hypertension, as Jeff mentioned, cardiovascular disease, renal disease, hypertension, hyperlipidemia, issues around sexual health, and social determinants of health, and anything really which impacts on stigma and discrimination. But really, I think we should be moving towards a more formalized and standardized approach of measurement and call to action.
Thank you.
So I'll be touching with Jeff on improvements of quality of life and where long-acting antiretroviral therapy can fit in. Jeff is going to be talking about the personal perspectives of looking at his experience with long-acting antiretroviral therapy. So Jeff, please.
Thank you, Iskandar. So I've been living with HIV for over 40 years. I acquired HIV 41 or 42 years ago, I know now. And by 1988, I had progressed to what they were then calling ARC, age-related complex, and I was having some symptoms. So I knew it was time to start therapy. But at the time, therapy was not available for people who didn't have a frank AIDS diagnosis with either PCP or KS. So my only option to access therapy was to volunteer to be a guinea pig in the clinical trials that were happening at the time with AZT, the only available drug. So I signed up for one of the first AIDS clinical trials group studies, was fortunate to get on the placebo arm because they were doing very toxic high doses at the time. And, as I realized that wasn't working for folks, I was switched to a different study and got active drug in 1988. And so that began an 8-year-long odyssey of single and then dual monotherapy and then dual monotherapy, which was, sadly the state of the art at the time. And obviously they didn't work. It developed resistance to them one by one. By 1992, I ended up in the ICU with PCP pneumonia, 2 collapsed lungs, and 2 T cells. I was fortunate to make it, through that and battled along until 1996 when protease inhibitors became available and we finally had effective combination therapy. So because of my pre-resistance, I had to, switch around regimens. I had lots of pre-existing resistance to both the nucleosides and to some of the protease inhibitors. But I was fortunate enough to find one that worked, became stably suppressed, and had been ever since. So fast forward 25 years, and I was on a kind of an oddball regimen of raltegravir, lopivir, boosted atazanavir, and Maravroc. Nuke sparing because of all my resistance and a very strong protease backbone. So it worked very well. But, as I mentioned earlier, I have inherited gastroesophageal reflux disease. So managing that with rilpivirine became a real challenge. And, I knew, working with my providers, that I should space out the antacids I would take. But often I would have breakthrough heartburn in the middle of the night and have to wake up and take another antacid. So then in the morning, I'd have to count the number of hours. Had it been long enough? Did I need to delay my dose? That sort of thing. So it became a real challenge. So that was my motivation for switching to a long-acting regimen. As an activist and as somebody who, advised drug companies who were developing these treatments, I knew all about them. And when they finally became available, I was ready to switch. Unfortunately, that was during COVID. And my clinic was not able to work through all the logistics. As you know, the American healthcare system is very fragmented and dysfunctional. So there were a lot of logistics to overcome. And it took about a year for that to happen. So when I did start, I found that was, those were the challenges, not so much the pills or the regimen itself. The injections were fine. I might have a sore butt for a couple of days, but it really did make a big difference in, managing my other comorbidities as someone aging with HIV.
Thanks very much, Jeff, for that very personal perspective on your initial experience with long-acting antiretrovirals. So maybe I could just come back to you. You mentioned initially your experience with long-acting antiretroviral was, in terms of side effects, was very minimal. So if I could just home in into specifically injection site reactions, did you have any problems with that? And if you did, how was it managed?
As I mentioned, it was basically just muscle soreness. I wasn't having redness or anything like that. It was just, a big needle going into a big muscle on both sides.
Okay.
And that's what I would feel. It's a couple of days, and I might take an aspirin, an ibuprofen or something.
Right.
It's really all it required, and just waiting it out.
Okay, great. Bernadette, if I could ask you, what was the psychological impact of having gone on to long-acting antiretroviral therapy and having few reminders of HIV status, which is often one of the reasons and the advantages of which have been cited for going on to long-acting ART?
Thank you. Look, for me personally, it's been a really big impact on me psychologically, not having to be reminded every day of my HIV status. And I feel at times that I'm not on treatments because I'm not taking a pill every day.
Would you ever consider going back to oral therapy?
No, absolutely not. I'm really happy with the injectable treatment I'm on, and it's working really well. I've got good results, and it's a very simple process. So, and I don't have to take a pill every day. I don't have to be reminded about my HIV status. So, for me, there's absolutely I wouldn't go back. No.
Right. Okay. Thank you very much, Bernadette. If I could go back to you, Jeff. With daily oral therapy, one of the challenges, of course, is having to take and build a discipline taking oral antiretroviral therapy on a daily basis. Did you have problems with that? And how has long-acting antiretroviral therapy changed that for you in terms of that sense of responsibility of having to be adherent to a daily regimen?
Well, in a word, polypharmacy.
Yeah.
When I first started taking antiretrovirals, I had to take medications to prophylax against OIs. I was taking 50 or 60 pills a day to cover the HIV, prophylaxis, the side effects of all those drugs, supplements and so forth. So over the years, I've been fortunate enough to be able to lower that dramatically, but I've never been a candidate because of my pre-existing resistance for, the simple one pill once a day regimens. And then, as I mentioned, growing older and having other comorbidities, I had to start adding more pills back in. So although it's not a pill-free HIV regimen for me, it is fewer pills, so that helps a little bit. But I still have to take pills twice a day. And I've always been grateful to have them, been fortunate that I tolerate them well. So that's really not my main issue, as I mentioned.
If I could go back to you, Bernadette. So the other thing which is cited as being an advantage of going on to long-acting antiretroviral therapies is the confidentiality issue. Could you probably expand on that, please?
Sure. Look, I think I feel a lot more free, not having to worry about taking a pill every day, and also someone finding out about my HIV status. So for 20 years, I felt like I just had to hide my medication away in the cupboard, just because I did, in the early days, I did have a bad experience where someone did actually find my pills and, started asking me a lot of questions I wasn't prepared for. So for me, that it's made my life so much more easier.
Fantastic.
Being on this treatment.
Great. Okay. So a positive effect there, certainly.
I'd like to thank all of our faculty, Dr. Azwa, Dr. Eu, Mr. Dedes, Mr. Taylor, and Ms. Sharp for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the slide set for this podcast and the full program on reaching the fourth 90, Can Long-Acting Agents Play a Role, on the Clinical Care Options website, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.